Let me pull all my stuff up here. All right. So yesterday we talked all about all the feel good stuff, and today we're going to talk about the challenges of the healthcare ecosystem. So I think it's a good mix up. The stuff that we'll talk about today is very, very deep in terms of complexity. And so we're going to be, at a very high level, just kind of scratching some of the surfaces on some of these topics. And the challenge here is, all of you have different backgrounds and different levels of expertise and experience across the healthcare system. So some of this you all may know, and some of this you may not know. What I'm going to cover today is at a high level, kind of how the ecosystem works, how the money flows, and what key stakeholders are looking for. And then when Jareen takes over after my presentation, she's really going to dig into what are each of those people looking for at a granular level? What are they listening for in your messaging? How do you tailor it for all of those different stakeholders and things like that? So that's what we'll be talking about today. Before I kick off, we do have a couple of housekeeping items from yesterday. First, thanks to everybody who provided feedback and input and for all your great comments. We debriefed after and just wanted to clarify one thing. Adam, you had asked about homework. We're not really assigning homework by session for the program. However, that strategic action plan with all of the empty fields, that really is meant to be kind of a living document that folks work on throughout the program. Sort of at your own pace, but you'll see that it aligns with a lot of the sessions. So I would encourage everybody that after the sessions or during the sessions to kind of have that pulled up, maybe take. All right, so why is this important? Well, healthcare is probably one of the most complex industries out there, and navigating it really starts by understanding how the players work together. More importantly, understanding where your product fits and how you're going to really angle and position is going to be key. The challenge here is for a lot of folks who've either not come up in healthcare or have come up in a very specific segment of healthcare, not across the whole ecosystem. When they start to launch a product or a tool or a service, it can be a little bit challenging to figure out where you fit, but also to figure out how to angle your product. That could be anything from what the product does to more commonly what I see is how to reimburse for it, how to get paid for it, how to pitch it. And that's really where having a good understanding of the entire ecosystem and how all the players interact together and how all the incentives are aligned or not really comes into handy. So, we touch on some of the topics here today at a high level. If anything, you'd like to dig down a little bit deeper specifically for your company, definitely note that for office hours and we can peel these layers a lot more. So just to set the scene, these are the key stakeholder segments that we'll be talking about today. I'm going to hone in after we do a high level overview on some of the ones that tend to be the key buyers of most of you all's products. But just in general, I mean, we have patients, and those could also be called consumers. That's anyone receiving care, anyone receiving any kind of the digital health solution or anything like that. Basically the receivers, the recipients, the benefits, the beneficiaries, if you will, of the care system, or also of the insurance coverage. Providers, I wanted to touch on this. There's a little bit of a semantic challenge in healthcare where some people kind of use different terms to talk about the same or different things. When I use providers, I'm talking about anyone who provides medical care. I've also heard providers use to just refer to medical providers. And then they would separately refer to hospitals or institutions. I kind of lump them all together. But when I talk about providers today, I'm talking about a health system, a hospital, a clinic, a medical provider, a doctor, a group. Really anyone, as it says here, delivering direct patient care is what I'm referring to. Providers, obviously a huge segment that can be broken out into subgroups. Payers, the big behemoths, of the world, of the healthcare world, they hold a lot of the money. They dole out a lot of the money. We'll talk about that. They're really facilitating and administering the financial aspects, as it says here. So getting money in to then pay for care, and cover patients, pay the providers for their services and all of that. Regulators kind of overlaps a little bit with the next bullet, which is the government agencies. This is a little bit challenging because you have certain regulatory bodies such as NCQA, the Joint Commission, even CMS. These are folks that are imposing standards on the healthcare system, whether that's mostly usually on providers and payers, to meet certain standards. and make sure that policies have certain levels of coverage and things like that. They're really trying to regulate the healthcare system. Where it gets a little bit fuzzy is that some of those regulators, primarily CMS, can also be sort of a government agency that's funding some of the healthcare as well. CMS is probably the biggest one, if not even the only one, but they are the ones that administer all of the funding for Medicaid, and Medicare, with some exceptions. And so those two kind of tend to get grouped together in my head anyway. Very different purposes though, depending what hat they're wearing. Vendors, this is a huge space. When we talk about the core ecosystem, we'll see on some of the later slides, like, there's key players: patients, providers, and payers. And government agencies are probably the big four that are really, in it. But you have all these ancillary people in the ecosystem, such as vendors and all these other things we'll talk about. And those vendors can be anything from providing services to patients or to the providers or to payers, or they could be suppliers. There's a whole bunch in the ecosystem. We'll talk a little bit more about that. When I say vendor, it could be anything from a technology vendor, such as an EMR like Epic, or it could even be a pharmaceutical provider or a med tech or diagnostic supplier. It could be people who provide lab tests to providers, to fuel their lab operations. Lots of different things fall into that space. So we'll talk a little bit more about that. Then we sort of have on the periphery the public health entities. These are things like our departments of health, our CDC, Centers of Disease Control, and things like that. I included them here because they are a major part of the healthcare system. To me, they've been a little bit ancillary to a lot of my work, and I'm curious to hear others folks' input when we get to the Q&A and discussion. But ever since COVID, I feel like they've been more and more present in the healthcare conversation. They've always kind of been, in my mind, over to the public health side, and there hasn't always been a ton of overlap or crossing, though maybe there should be more. But they're definitely starting to emerge and have much bigger hands in the healthcare ecosystem. Public health entities, for instance, here in New Mexico, they're getting really involved in things like housing our all-payer claims database, which is purely just medical claims and information about cost of health care, not even just in Medicaid, but across all of our payers. And so we're starting to see them launch and deploy rehab clinics and public health and community health departments and behavioral health and substance abuse clinics and things like that. So they're really starting to get really involved. And the manufacturers, as I mentioned, could possibly be considered under vendors. I think, maybe is a little bit cleaner to think about the manufacturers and the suppliers separate from some of the technology and services vendors, but we'll talk a little bit about how that all comes together. So this is a high level of just kind of a slice of everyone who's in the system. Before we dive into all of that, though, I just want to do a reminder. This is mostly for myself as well, as you'll hear a lot, don't forget the patient. And I think that especially as vendors, a lot of the times we're selling to a payer or to a provider, and we're somewhat removed from the patient care. Really just a call to action to kind of recenter and always think about, how does this impact the patient at the end of the day? Jareen's actually really, really big on this. Experience, obviously outcomes, things like that. It can be easy to get mired down in I'm selling you this tool or product that's going to reduce your total cost of care, and save money and have this ROI and stuff like that. But let's just always remember that those dots on your screen, on your graph or whatever, are all people. And those are really who we're here to help. And I'll show you a little bit more about kind of how it all comes back to them, even financially. So I'm not going to go through this. I thought this was just a simple screenshot for folks for reference. It kind of summarizes everything that we talked about. This graph, though, the reason I liked it is because it also included startups and academia sort of as their own category. So as you can see, this ecosystem's kind of growing and bigger and bigger. So that's a high-level overview. Let's dive in a little bit more. We're going to peel back a layer. I'm going to really focus in. So we talked about all those different stakeholders. I'm going to really focus in on the folks that are going to most likely be most of you all's target buyer segment. So while there's all these ancillary things, public health systems and things like that, that's good to know that they're there. But really, I think the bulk of what we're talking about with our services and tools that are represented here today are selling to or helping patients, selling to or helping payers, providers, and then we kind of fall into the suppliers/vendor space. So the reason I'm showing this, and I'm going to go through this graph in a little bit more detail, but I liked it because it kind of segmented it out to those 4 big buckets: patients, providers, payers, and vendors, I'm going to call them. But the ecosystem is really huge. The healthcare system is, an interconnected system of public and private and hospitals and things like that. This graph I really like because it just simplifies it all this down and also shows these lines are really kind of where the money flows. So the reason it's labeled here as value chain is because this is really more of a view not only of the ecosystem as a wider thing, but the value chain specifically is how that money flows. And we'll talk through that. And Jareen will talk a little bit more about deciding where you fit. So this is kind of a reference slide. Let me just check my chat. Will we get copies? Yes. Yes, thank you. Okay. As I mentioned, in suppliers, this is where I'm going to lump everyone else: technology, health information, other vendors, digital health. Okay. So the reason I wanted to pull these up and really go through them is to just show the types of different verbiage, semantics, and groups, major groups that fall under each of those big buckets, because these are the folks most likely that you'll be selling to and helping. So on the left here, I was calling them patients. Jareen also refers to them as consumers very often. They may be private pay, but most likely they're paying into some insurance or something. But again, they're the recipients. So this is patients and their families, but it also includes employees. When you're in an employer group, you get insurance through your employer. You're a patient, but you're also an employee. You kind of fall into this patient and consumer group. It can also be communities. We could be deploying services or tools that help communities. They may not directly be a patient of medical care, but anything about the individual who's the recipient. These are some examples of further breakdowns of that. Moving to the right, the healthcare professionals. I included these folks because though you will probably most likely not be going into a hospital system and trying to sell a service, say to an individual nurse or directly to a nurse or something like that, the reason these folks are really important is because they comprise this whole care delivery system, and oftentimes are the folks you're going to need to talk to, speak the lingo of, and win over. And I just wanted to illustrate just the sheer amount of different types of folks that are in this group. So, I mean, yes, we of course have clinicians, but there's also what I would consider like the allied health, like the physical therapists, occupational therapists, athletic trainers, things like that, allied health professionals. There's pharmacy, mental health professionals. That's where we get all of our social workers and our counselors and our psychologists. There's a whole group for healthcare administrators, executives, clinic managers. They all speak a certain language and are listening for certain things. Then I like to include, because I'm in this bucket, is the health informatics and support staff. So these are the folks like the billers or the billing specialists or the analysts or the health information technology implementation teams and things like that. They will have a big say in everything that you do. And then of course, public health professionals, again, they're kind of on the periphery for me. We have R&D folks in there, medical scientists, researchers, EMS, again, kind of an ancillary service, paramedics, emergency medical technicians. So the reason I wanted to illustrate that is just as we, this is to set the stage of the lay of the land, but as we start to think about how our tools and services fit in here, who are we helping, whose lives are we making easier, what outcomes are we influencing for whom, whose workflows are we impacting, things like that, all of this comes into play. Providers, the third column there, this is so far and wide. So again, this is to kind of get you to start thinking about where does who do you serve? Where does yours fit? Again, Jareen will talk a little bit more about the nitty gritty, but just as an example here, we have things like primary care, specialty care, outpatient clinics, ambulatory clinics, urgent cares, emergency departments, long-term care, rehab facilities, so on and so forth. Each of these are going to require, depending on who they are and what they do, a very tailored, a very specific talking point, pitch, value proposition, even if you're, pitching the same tool or service across, 3 different ones. And then on the far right, payers. Earlier, I kind of said, those are the behemoths in the room, and they are. you hear the term payer a lot. Sometimes you see it spelled payers. I'm still haven't, I'm on the team E, but this can be health plans. They can also be called health insurers, carriers. You may hear them managed care organizations. Those mean a little bit of different things. The managed care organization means that I receive money from a government entity like CMS or the state Medicaid agency to then manage the care of a Medicaid population. But I can be a managed care organization doing that for Medicaid. I could also be a payer administering employer insured groups insurance for all the employers in New Mexico as well. So kind of colloquially, I just call everybody payers, but there are nuances there. And there's also government payers that aren't like the Blue Cross Blue Shields of the world, but things like TRICARE and VA, even Medicare and Medicaid, when they're directly administering benefits to recipients directly and not going through a managed care organization, can also be payers. So the payer column is big, it's wide, and an often overlooked group here is employers and self-insured groups. I think a lot of folks here actually have some tools and services that might align really well with the employer groups. And I feel like they're often overlooked as a payer, especially the large employer groups, people like who have a national presence. They pay for their own health insurance. They just contract through a Blue Cross Blue Shield to administer it and all the claims and stuff like that. But that's a really interesting market segment. Well, I'm sure we'll talk more about that. I don't want to go through this slide too much of the detail because it's very similar to what we talked about. But again, these are just to kind of show more about the ecosystem kind of as a whole. The one that I do want to touch on here, though, is this vendor column. Again, health IT, digital health. This could also be virtual care, wearables. This could be where our analytics companies fit in, things like Pine Donut. So that's a really important segment. And I think one of the angles that I've been pushing for just in my career is a lot of times, you can say, oh, I'm a vendor or a service provider or a technology provider. And a lot of times people see us as ancillary. I say that us because I've always been in that space once I started into entrepreneurship. And when you start looking at the ecosystem, you actually realize that we're just as much a part of that healthcare ecosystem, and we're just as much a part of making all of this happen as some of these others. And so I really like to just continue to include vendors in there, push the collaboration across the ecosystem, really highlight the importance that without vendors and services and technology, like healthcare wouldn't be what it is. And so just always kind of remember it can be hard because one of Angelica's favorite sayings is a vendor is a 4-letter word, but I think that, there's a real paradigm here that we're trying to advocate for, which is, we're just as much as part of this ecosystem, and we're here. We're actually right in the middle, kind of orchestrating everything as a vendor. So, all right. This is a very, very, very complicated image, and I'm not going to go through all of it, but the reason that I put it here is so that y'all can go back and look at this if you're interested. This, I call it interactions. You could also kind of think of it as incentives. This really shows a lot of those big categories that we talked about. So for instance, physicians, hospitals, government, patients, it's got all those big bubbles there. But it shows all of the different incentives and how everything impacts everything. So you really need some time and some brain power to sit here and follow some use cases through, but it's kind of a good nifty cheat sheet. It's called a system diagram that attempts to show how the different incentives are trickle through the system. If anybody is interested in any of these or wants to dig down with me, I would love to pick this apart with you. We're not going to do it here today, but it is here for reference. There's also a more simplified version that kind of puts the patient at the center and really focuses it from the patient perspective. I think this is really important because a lot of times we forget, as I mentioned, about the patient. And again, there's links to everything. You can go look at these afterwards, but this is really neat because as we talk about the ecosystem, we're all here trying to help move some curve, whether it's outcomes or cost or quality or whatever. And really at the end of the day, it's going to come down to what the patient does and how. And that's why I like this system graph, one, because she simplified it, but two, because it really focuses on their journey and kind of how that trickles through. So not only do you have to think about the bigger ecosystem and the reimbursement structures and how you're going to fit into that, but you also kind of need to think about how's that actually on the boots on the ground going to impact this patient, and what are they going to do differently? And how do they interact with the health system differently because of what you're doing? So Again, just another really interesting graph to illustrate the ecosystem. All right. So as I mentioned, we kind of went through that at a pretty quick clip. I'm happy to dive into, I got some private messages here to dig into this a little bit deeper on office hours with some folks. But what I want to talk about here is knowing all of that, again, focusing in on those primary key stakeholder groups that you'll most likely be the ones pitching to. So again, patients, providers, payers, and maybe government agencies. What do these folks really care about? When you walk into a room, you can say, I have this great technology or tool or whatever, and it does all these cool things. What words are they going to be listening for that's going to really perk their ear up? This is going to be an entree into what Jareen will dig into in much more detail in hers. So patients and consumers. I'm not sure if we have, we have a couple potentially direct to patients or consumer folks here in the group today. But in my experience, it's been all about cost and their experience or satisfaction. So to me, and you think of yourself as a patient or consumer, if you're going to try a new app, it's going to be, how much is it going to cost? What's it going to do for me? How convenient is it? And then there's obviously, for folks who have multiple chronic conditions or health problems, there's a significant, is a certain service covered and can I get access to a provider? Here in New Mexico, obviously that's access is just a huge challenge. We don't have exactly a plethora of specialists. We see that come out in some very adverse ways. And so, that's a very important thing to patients, is where can I get the care that I need? Is it going to be convenient? Am I going to be treated with respect and dignity? How much is it going to cost and things like that? This is a food for thought slide regarding patients. And I thought it was really interesting to put in here to tee up your thought as you think about your value proposition and you take this away. What I'm explaining right now is sort of the status quo. There's a very big push right now for innovation, digital health, patient-centered care, things like that. And so I thought this was a really interesting slide, going back to my call to not forget the patient. McKinsey actually does postulate that the ecosystems of the future will be centered on the patient. I do agree in some ways. I think the incentives right now are a little bit challenging, but really at the end of the day, we're starting to see the emergence of like really neat digital health tools, really neat fit tech tools, concierge medicine, direct to consumer medicine that completely bypass payers altogether and things like that. So I wanted to put this here for you all to start thinking as you kind of maybe think about a forward product strategy that might, help you with getting ahead of the curve. And I'm sure Jareen has lots to say about consumerism and direct to consumer. So that was an interesting slide, and all the links are there at the bottom for you. Okay, again, I put healthcare professionals in here because though they don't tend to be the direct buyers and sometimes not even, unfortunately, the direct decision makers, they are the folks you're going to have to win over because you'll hear things like, we're too busy for that. I've heard direct quotes just recently, actually, from a former hospital administrator who said, I used to think that vendors, they'd come in and say that their technology was a silver bullet. And I'm like, yeah, okay. Can you tell me how to staff my, my 5 beds right now in the ICU, because we're short staffed and, on the brink of bankruptcy here. So keep that in mind, though you won't be pitching to these folks. These are the things that you'll tend to hear from them. They care probably the most about the patient. They're the ones dealing and serving the patients. We'll always ask about that. But a couple of other things that I've noticed in my career is anything that you can do to help with efficiency, burnout, but most importantly for me, like minimal change management. So as you're thinking about when I come in and I'm going to do something or launch a tool or something, if it's going to require, like all of the ICU to completely redo their workflows and adopt a completely new system and everything's changed, like that's a very challenging sell or argument. Can be done. But I think thinking about how to sort of get things in there in a bite-sized way and how that's going to interact with the workflow, those are things that the folks here doing the work who don't have a ton of time are really kind of regarding some of these things. And then sustainability, to me, that's basically the longevity of where they are. So we hear a lot in the news about, these major hospital systems with these huge profit margins. Those are, though they exist, there's sort of a very wide disparity between, our rural hospitals, rural and smaller and more private hospitals, that are kind of on, very, very, very slim margins. And then you have some of the biggies in the world who are in the news for having really huge profit margins. But that disparity is growing. And so I think sustainability, because workforce is a big issue. So folks working in the healthcare space, especially at the administrator level, are thinking a lot about sustainability, honestly. And so it's hard sometimes, I think, for folks to be very forward thinking on some of these really new, cool, innovative, game-changing things when they have right in front of them some very real sustainability challenges. Again, this is kind of based on my experience and those of others and things that I've heard. I'm interested in the Q&A to hear others' thoughts. Providers and institutions, probably one of the biggest purchasing segments. Again, this is anyone providing any kind of care, has hospitals, clinics, so on and so forth. Lots of things that they could be worried about, lots of things that they could do, and lots of ways I think that they could implement technology and innovation to really improve things. But I think revenue and quality still, in my experience, rule conversation. So as we get further into our program, thinking about, yes, our tool may improve, care coordination workflows or something, say, patient communications or patient experience. Any way that we can tie this back to a revenue or a quality outcome is going to have a better chance of pinging people's ears and getting their attention. If we can tie it back to some documentation improvement or quality measure improvement or something like that. And we have a whole session, a whole 2 hours dedicated on how we can think through some of that. But I just think revenue and quality for providers. Additional to that, as I mentioned, with sustainability, workforce retention is huge right now. So virtual care, things like that are very enticing. I think telehealth expansion of capacity has been very successful. And then kind of on the last bullet there, efficiency and improving care, despite the rising costs of healthcare and the shrinking margins, basically doing more with less. So there's a very big push right now on efficiency and a lot of interest in that with AI and how that could maybe help with minimal revamping of all of the workflows and some, and change management. How can we be more efficient and do better care with less and shrinking reimbursements potentially? So again, everything's kind of back to that revenue and quality with this. And finally, payers. Payers care about the health and the corresponding costs, of course, of their population of people that they cover and their subpopulations. So things that tend to perk their ears up are going to be things that reduce or help to understand and manage the total cost of care. You may also hear it referred to as PMPM. It's not quite the same thing, but that's how they measure it. So how much am I spending on a population of people, whether that's a employer group, like I mentioned, or a Medicaid group or a subgroup of Medicaid? That's very important, things that will perk them up. Another thing is similar to the providers. Payers are also beholden to quality measures that are directly impacting of how much money they then receive to provide care to some of these members. So you may have heard of HEDIS, which is I mentioned the NCQA regulatory body. HEDIS is the set of measures for quality for payers. Again, we have a whole program, a whole session dedicated to talking through some of these, but the higher you score and the better you do on these, the more money you eventually get to provide care for your patients or for your members rather. And then if you can do that for a lower total cost of care, thus your profit, it can be a little bit wider, or your medical loss ratio can be a little bit better. So they really care about, reducing costs or at least managing it. High quality, eliminating things that are low value, high cost, things like that are very, very top of mind. And they have been, at least for the last 15 years, I've been working in this space. Second to that, I would say probably reimbursement. When we talk about reimbursement from a payer perspective, that's how much do they pay to a provider to provide the care. Lots of very challenging dynamics here. Again, happy to talk through this with anybody. Some of you actually sit on both the provider side and the trying to help a payer side, so you probably see some of this. But one of the challenges that I've seen in my career is payers are still always like, how can we recontract with providers, which basically means pay them less. Like they're not, reimbursement rates aren't going up. That's part of the reason that they're really interested in moving to some of these value-based care models, because they want to control these costs, but they're also always looking for ways to sort of squeeze money out of the reimbursement. And it creates a really challenging position, not only for the providers, of course, who have sustainability problems, but also for vendors who come in and are trying to help or fit into this space. I don't know the answer to this. This is very multifaceted and very complex. I've worn both hats. I'm happy to just kind of talk through some of this and how to balance those competing incentives. I think there's a way it can be done. And we have a lot of payers who are really forward interested in trying some more of these value-based care models that maybe don't always just require, ratcheting down the contracted reimbursement rate every time a contract renewal comes up. So I still just, reimbursement is still one of the main levers I think that payers think that they can pull in a way to control some of this total cost of care that they're so concerned about. And finally, growing membership. Basically, the more members that you cover, the more money that comes in to cover those members. And then if you can control that total cost of care, then that helps your medical loss ratio, AKA profit and things. All right. Another food for thought slide. I'm not sure how much I think this is a really great theoretical slide, but again, just as you all are trying to get ahead of the curve and trying to think ahead of like where you may fit in and how you may differentiate. This is another one from McKinsey, which is really interesting. And they postulate that this is how digital health could benefit both payers and their partners. I think a lot of this is true. There's the value proposition there across the top with the icons. But what we need to really think about here on this group is how do we then kind of tie that back to some of the things that they care about that's going to get them to say, yeah, okay, then I'm going to sign the check because you're going to do all these things, but at the end of the day, here's the whatever needle or metric that it's going to move. So these are kind of interesting, I think, emerging trends in the digital health ecosystem. This was a cool tool from Oracle. You will get these slides and you can go to this link, but if you click on these little red dots, it kind of summarizes everything that I talked about. So for instance, here's cost of care. If you click on this little red dot, it'll bring up another table that shows you, why do people care about cost of care? What are some of the levers you can pull? What's top of mind right now? So for instance, I pulled up one for care delivery or providers, basically. What are their key challenges? What are some examples of why that's important? What are some use cases and possible solutions and things? I thought it was interesting that Oracle put this out, but it's kind of an interesting little reference tool to refer back to. All right, so that was the big high level quick overview of primary ecosystem dynamics. What I want to talk a little bit about is typical reimbursement models. The reason I say typical is or kind of giggle when I say typical, is because there's not really a typical. There's many, and it's going to depend how you're reimbursed, how you as a vendor are going to be reimbursed is one, a major question in your business model and something that you kind of need to think about early. But also it really depends on who you're selling to, who's paying for your service. So it may look different. Your business model or your pricing model may look different for if you're selling something to a provider versus the payer because of how they get paid and because of how they're incentivized. And so I want to talk a little bit about that, because to understand all of that, you first have to understand how the money flows. And that's technically what is meant by the value chain. Ecosystems, kind of the whole, everyone in the space. Value chain is really how does that money flow along every step along the ecosystem. So I'm going to go back to our value chain slide, our simplified one. Again, this is highly, highly, highly simplified. Lots of nuances and special cases, I guess, to everything that I'll talk about today. But again, I'll just reiterate to understand how stakeholders are paid, and then that ultimately is going to be how you're going to be paid. You have to understand how this money flows, because how you're going to get paid depends on who and how they're paid. So if you try to follow the money, you'll start to see the complexity of some of these compensation schemes. So I'm going to start here. At the end of the day, we're going to start on the right with the patients. At the end of the day, a lot of this care and a lot of the healthcare costs is coming from the patients. They're the ones who have the money, whether that's through paying taxes or earning wages that then goes to their employer for health insurance, things like that, where the government gets money to pay for healthcare. Like a lot of that comes from us as people, and as the economy and as patients. So with some exceptions, of course, but a lot of the money kind of originates there. So the way that patients may pay for care, they may pay directly for care. So you see they may pay directly for, if you follow this line over here, to some of these suppliers or vendors. So this could be like digital health, things like that, pharmacy, things. So that's direct pay. More commonly, they pay some premiums, typically to their employer, who then kind of amasses it and basically commissions a payer to administer that employer plan, like I mentioned. That's called TPA, or third party administrator. There's some nuances here because the employer can be self-insured, which means that they pay for all of the expensive medical claims out of their own pocket, or they may contract with the payer to take on the risk and pay them like a PMPM basis, depending on how many employees they have. But either way, patient, employee, or member pays a premium for the payer to provide employer care. That's one way that the money flows. Now the payer has it, right? And then of course I mentioned, taxes and other things that kind of outflows. And that's where some of the government and regulatory agencies get their money. So as you see, everything's kind of, coming out of us and into these major this major payer line here, regulatory agencies or payers. Now, once the regulatory agency has, this is things like CMS, Medicare, Medicaid, they may administer those funds directly to some of these providers through direct fee for service, or more commonly, they may contract with a payer to, again, administer these programs called managed care. Again, that's typically in a PMPM basis. So, I'll use a concrete example. State of New Mexico, Medicaid gets some amount for their budget every year as the regulatory agency. They do some match, and they also get some federal match, comes from a government funding. Then they disperse some large portion of that dollar to 3 different managed care organizations: Blue Cross Blue Shield, Presbyterian Health Plan, and now Molina in the newest contract. They disperse all that money across to these 3, and they say, okay, here's your big bucket of money. Now you all manage the care. And so now the payer has it as a managed care organization, and now the payer doles it out and pays all of these providers for care. So, everything kind of starts with us, goes through government and through the payer, through the employer, and then kind of is doled out to the providers who provide the care. So I know this is very complex. It's because there's a lot of bidirectional flows and a lot of different ways that the money flows. But I think this is probably the most simplistic, if you can believe it. And to add another bit of complexity on top of this, or potentially opportunity, as I mentioned, there's all these ancillary types of vendors and suppliers that can be providing services to literally any one of these major groups, a payer line or a provider, or even a direct to patient. And so all of these crisscrossy lines on the graph actually indicate that, yes, a hospital can actually be purchasing some of these services, or a payer could actually be purchasing some of these services. And this is where we fall. This is where our EMRs fall. This is where our telehealth vendors fall. This is where our outsourced claims, authorizations, and denial companies for payers fall. I mean, so much stuff in here, and the money is just bidirectionally flowing every which way. But I think this is probably the crux of it. This kind of summarizes what we talked about: how you're paid. It's going to depend on what you're doing, for whom, and how they're paid for what you're supporting them to do. So this lists some of the most common, certainly not all, of the different types of business models that these different stakeholders may use to either pay you for, most likely pay you for a service or product or tool, so a vendor. So for instance, I'll walk through how this works. So a patient / consumer, if they're purchasing a vendor solution or something, they may pay out of pocket, they may do a subscription model, or it may be like a one-time fee. And again, these are just the most common that I've seen. I'm sure there's plenty more. Doreen, if you have any to add here, during our discussion, I'm eager to hear what you have to say on that. Providers and health systems, they may be, so say they say, okay, yes, we like your tool technology. We're gonna do business with you. Your tool or technology helps our providers. We'll pay you on a per provider per month or per provider per practice basis. So if we have 100 providers using your tool, we'll pay you 100 times X dollars. That's one way. Another way is if it's like a system-wide or a big financial operation or, some kind of like a one-time project or overhead. I've seen it directly paid out of overhead, out of someone's budget as a lump sum. I've seen a lot of licensing and subscription models. You could also potentially be paid based on the size of your pilot program. So again, we'll talk through a lot of this. You'll see some of these in your strategic action plan to think about your business model and how you're pricing. But happy to talk through any of these examples with folks to think about what really makes sense for you and how might it be different if you are pitching one day to a payer and the next day to a provider, because your tool may very well help either, but you may just need to structure it a little bit differently, knowing how that money flows and knowing what's important to folks. Payers, again, I think a lot of folks like to focus on trying to sell and get in with the payers, mostly because they do hold all of that money. And you also do see a lot in the news about their profit margins and things like that. Managed care is huge. Government programs right now is huge, but this one I've seen anything from like a flat rate, like I said, a flat service fee. When Angelica and I got started with VMA, we were doing kind of these ad hoc analytic service projects, and so they would if the Medicaid, the VP of Medicaid was our first client, she came to us and said, okay, I need you to do a big benchmarking study. She pulled it out of her budget. It was a big flat fee. But more commonly, if you're like a population health tool or some kind of digital health tool, we see more of a PMPM type of a payment structure. So if you enroll 100 people, you get 100 people times X dollars to use your service or whatnot. More emerging more now, though I still haven't super seen it be very successful, probably because there's not a lot of data yet to support it, and a lot of folks don't tend to think about outcomes or measurement until way after the fact. Again, we'll have a whole session on that. But I'm seeing a lot more of this pay for value or shared risk arrangement. We see this a lot with things like chronic condition management programs. So you maybe have like a group of 5 doctor specialists who say, we specialize in sickle cell anemia or some chronic condition, and we're going to come to you as a payer and say, okay, we can manage your sickle cell population of folks. We think we can reduce their total cost of care by $100,000 a year, and we'll take 50% of that savings, and then you'll reap the rewards of the other 50% through reduced total cost of care. So you're sharing in the risk, or you're getting paid on a pay for value or value-based care type of an arrangement. These are much more risky and much more challenging to show and to have everybody on the same page and in agreement on what that was. This also kind of ties into plain old value-based care with a payer and a provider as well. Again, happy to talk through any of these. Similar to the bottom one, performance-based incentives or bonuses. I see a lot more of these because this is a little bit more what they call upside. Basically, we're not doing anything for free on the contingency that we improve some metric, but we're doing something for some flat fee. Maybe it's a little bit lower, like a PMPM or something. And then if we do see that 100 grand of savings, we'll also take 10% of that. So you just have the upside and none of the downside. So again, lots of different ways to structure these. It's going to depend on what your tool does, how they're paid, what you're doing, who you're supporting, how much it's going to save, all this kind of stuff. So probably something we should definitely talk through if you're interested. Finally, government entities. I put them on here. I don't think most folks will sell directly to government entities for a number of reasons. It's it's a challenge. It's not impossible. You may be able to go to a state Medicaid agency. In fact, we've done that, and say, hey, our tool or technology can improve Medicaid as a whole. But a lot of times it opens up opportunities to be paid in a little bit of different ways because of how government entities are funded, just regardless of being in healthcare. So these are things like grant funding, pilot programs. You can do more, contractual kind of big lump sum type projects, as well as potentially be funded through the government to provide technical assistance to providers or to payers or something. So that's a whole other kind of ball of wax, but there are different avenues. And the reason I wanted to illustrate all of these different things is because it's really going to tie into what you pitch. And I also would really recommend kind of having this a little bit buttoned up before you go in, so that when people kind of ask about cost or something like that, you already at least have an idea of how to price and then how that scales as more people in your pilot scale or with the size of the project or whatnot. Again, I think Jareen will get into some of this a little bit more, but so I think I have 2 more slides left. I think in conclusion, one size does not fit all. I think, that comes across pretty clear. You will hear this theme throughout the program on just about every presentation. This, as we just talked about, the ecosystem and the reimbursement landscape is one of the many reasons that a one size fits all approach does not tend to work. The easier you can simplify it, the better. But just understanding the different incentives, the different points of interest, the different hot buttons, if you will, of the different types of clients is really going to benefit you. And we'll talk in a future session about how to use data to help think through some of these things ahead of time, ahead of a pitch. But again, just wanted to stress the importance of understanding all the stakeholder specific challenges. And again, reiterate that you may very well have a couple of different models, but it's very important to kind of model that out and to see, okay, if we launch a pilot based on the cost of our technology and our team and stuff like that, what's our break even point? How many people or how much would we charge per month? How much do we think we're saving that? All of that stuff fits in. And it's really important to understand all of that. So some strategies just to kind of sum all that up in a sort of actionable takeaway. Here are the kind of concrete next steps to think about to do all of that. And we will talk about most of these things in much more detail during future sessions throughout the program. So I just kind of wanted to do a clean up of it. But first, on the upper left here, researching and understanding the needs. We'll talk in a future session about how to use data to do some of that stuff and how to kind of craft a compelling pitch ahead of time, or at least come in with some preconceived ideas of where and how much you might be able to help. ROI in the middle, upper left, up in the middle up there is key. Oftentimes we think of ROI as a financial ROI, which it does kind of come down to that quite a bit. That could be a potential savings or a revenue increase, but I also like to expand ROI to be, if you can show it with numbers and data, an increase in satisfaction or an increase in quality scores or an increase in engagement or something like that, that can also be ROI if you pitch it and think about it in the right way. And so we'll talk a little bit about that during our outcomes first session. Upper right, testimonials. That's always important. Anytime you have a use case or a study, to show some of this stuff. If you don't have one yourself, there's lots of literature out there that you could potentially pull from. Again, anything you can use to show this has been done. And if it hasn't been done, here's why we think it's going to be really valuable. The literature says this and da-da-da-da. And, that kind of stuff I think is really helpful, because what I've noticed is a lot of folks don't want to always necessarily be the first ones to try something because of all of the competing interests that I mentioned. It can be really challenging. Bottom left, continuous training. That's really talking about hands-on support and how we can really get in there and be sticky. We'll talk about that in a future session. Compliance. The more you can be compliant and have all of this stuff kind of figured out up front, the less of a headache or thing to worry about it is for your buyer. And that's just reducing the friction to get in there. We have a whole session coming from a CIO's perspective where she will talk about digital strategy and compliance to kind of make sure you have those check boxes marked. And then again, on the bottom right, outcomes, we'll spend a whole session on this, but how do we link what we're doing to some kind of outcome? It doesn't have to necessarily be financial. Most likely it'll be, quality or financial or engagement or something, but got to show some kind of moving the needle. And how do we do that? And if we can't do it, how do we start thinking about what data we need to do it? And that'll help us navigate this very complex ecosystem that I talked about. All right, that was a lot. I was actually going to try to get through that in 30 minutes, if you can believe it, so that Jareen would have more time. But all right, that's all that I got. So what questions do you all have for me?